So I have been tasked with telling you about syphilis, and I'm sure a lot of you in the room are already experts in this disease. You're all thinking about it and managing it every day in your practice. So hopefully I'll give you an update of some new epidemiology in the U.S., some new epidemiology in North Carolina, and then some new research that we're trying to figure out how to have an impact on this disease in the U.S. I don't have any relevant disclosures that are affecting what I'm going to tell you. This is where some of my funding comes from. And I wanted to start with some pictures. So even when I trained in Atlanta, we didn't have dark field microscopy available there, but this was a really nice way to make a diagnosis of that chancre. You could do a swab and tell the person immediately that the chancre was due to syphilis because you saw this treponemal spirochete with a very classic corkscrew shape. So what we're going to focus on today, my interest is really in women and infants with syphilis, but we'll talk about men. We'll talk about HIV-syphilis co-infection. I want to make sure everyone's up to date on what the current screening recommendations are, the treatment recommendations, and again, a little bit about new research. I don't mind if you have a quick question while I'm speaking. If there's something that's not clear, just raise your hand. So the first point, I think, to set the stage is that although, yes, we are talking about an increase in syphilis in the U.S., if you look here at the right hand, this is nothing like the 1940s. So fortunately, we do have effective antibiotics still. Penicillin remains exquisitely effective against T. pallidum. So the increases we're talking about are relative compared to the 1940s. We would like to not get back there again, ideally. And the South is almost always the top of these HIV-STI charts, just to show you, since we're in the South, that we're not number one in this anymore. Woohoo! The West has outpaced us, but the West and the South, if you look at this map, this is why it's important in North Carolina and South Carolina and Georgia and Alabama and Florida and California for us to be real experts at managing syphilis because we are seeing it whether or not we recognize it. There are different breakdowns by gender when you look at different STIs. You know well that chlamydia is an infection that predominantly affects women. Syphilis is an infection that predominantly affects men. So that doesn't mean that women are not impacted by syphilis, but the majority of cases, this is 2017 data from CDC, occur among men. And for the age groups, you can see mostly between age 20 and 34. And this is showing you the racial disparity of blacks at the top and continuing to rise, although there rises in every racial and ethnic group in syphilis. This is primary and secondary disease. And we have known for a long time, all of us who work in HIV clinics, that the problem of syphilis in men who have HIV is particularly significant. We had 150 cases of syphilis in our clinic of 3,000 patients last year, about 2,500 of whom are men. And you can see if you look overall by gender and sexual preference, men who have sex with men with HIV are a really big part of what is happening, which is a big problem, not only because of the possibility of transmission of HIV to uninfected partners, but the transmission of syphilis to uninfected partners being a harbinger of risk behaviors and a risk factor for HIV in men who are not yet infected. The reason that Dr. McNeil and so many people in this room spend so much time training on STIs is that although we have really great STD clinics where they know how to do frontline management and diagnosis of STDs, most patients, many patients, men, women, and MSM, are being seen by private physicians. So I get calls from private physicians who say, I haven't thought about syphilis in 30 years. Can you tell me what I need to think about? Or someone in the emergency room who is just not comfortable, even though they have a lot of STI, they're coming in for their complaints. They're focusing on the gunshot wounds. They think the vaginal complaints are maybe less interesting. I don't know. Don't want to put words in their mouth. It's important for all of us to be comfortable managing these problems because if we think this is only going to be fixed by the STD clinics, they're not seeing the majority of the patients. Obviously, congenital syphilis is a travesty that it's even happening in the United States. The rates have been increasing 155% in women since 2013. That's this black line, a primary and secondary disease. The congenital syphilis rate obviously tracks directly with the rate in women, and this has increased to 918 cases reported in 2017, something that we thought in 2000 we were literally wiping off the map. So what's happening in North Carolina? This is another map similar to CDC data where you can see the year on the x-axis and the number of cases on the y-axis. Men are in blue and women are in purple, so not that women are not some proportion of the cases, but the men are making up most of the cases. And you can see a significant increase in North Carolina, matching with national data after 2014. Pretty flat line after 2015. And if you look at the racial and ethnic breakdown, the blue lines are black and the green lines are white. So majority, you can see somewhat decreasing proportion among African Americans between 2015 and 2017. And this is where I have a question for you, because I don't know North Carolina geography very well, but is some brave soul in the audience want to tell me why you think those 4 counties have particularly high rates? What's happening there? What's the story? Urban areas. Okay. So these are rates. Obviously, they're calculated by populations, not just number of cases, but we do tend to see more syphilis in urban areas. It's not only in urban areas. Anyone else have anything else? Is urban the only explanation for those hot spots? Great. So that makes sense, because when we think about a lot of syndemics for HIV and STI, we think about places where people come together, and rates where there's highways and drug use are clearly going to be risk factors for that. So that makes a lot of sense. So tell me why. Why? Because I would think social networking you should have even rurally. But wouldn't that be an argument for rural cases, for people rurally finding?
I live in a rural area. Who would want to go 10 miles up the road when you get down the road?
I see. Yeah, please.
Public transportation.
Okay, tell me more.
Because in the Guilford County, State County, and the colors there, you have 4 lines of bus routes from buses. But you don't see them out towards the rural areas.
Okay. And this is the same transportation point that she was bringing up, I think, right? Highways and places where roads are coming together?
Well, yeah. Well, just things too, like the social economics and then the lack of transportation.
Right. Yes. Great point. You guys are hitting all the major things about syphilis. I think one other person had their hand up in the back. All right. If we could talk about just this. This is fascinating to think about what your local patterns are. Because if you're going to impact syphilis in your community, you have to know what the drivers are. And the drivers in North Carolina are not going to be the same as the drivers in North California, right? They're not the same. This is early syphilis percentage of people with HIV by gender. So the same colors, blue for males, purple for females, to show you that in males, approximately 50% of the cases of syphilis that were picked up in these years were people who also had HIV. So I have had people in my clinic come into me with new HIV and syphilis and hepatitis B and gonorrhea and chlamydia at the same time. So these are the cases of congenital syphilis in North Carolina with the same pattern that tracks what we see nationally since 2013. You'll notice that a lot of these are presumptive and probable, meaning that the diagnosis was made late or the woman may have been treated late in pregnancy, not necessarily that the infant was symptomatic or had actual evidence of congenital syphilis. So what are the screening guidelines? We depend on USPSTF to look at all the best data and tell us which diseases we should screen Americans for and which diseases we should not screen Americans for. And syphilis consistently gets a grade A recommendation, whether you're looking at pregnant women or non-pregnant men and women. Syphilis screening is very cost-effective, very few drawbacks. The gray zone really comes in the screening interval. How often should we screen? Should we do it more often in people who are high risk, who have history of STI, who have HIV? This is where USPSTF says our data really falls short. We don't know how often to screen. We know that CDC tells us for HIV-infected adults who are having sex, we should look for syphilis at baseline and every year. But we also know in high-risk MSM, we're screening them for STIs every 3 to 6 months. Should we be screening more often for syphilis now since we're in the midst of a syphilis epidemic? I think yes. We're trying to put some data together to be able to back that recommendation up. Even the HIV Medical Association doesn't have a definition of screening frequency. They say just based on risk. And when you have guidelines for providers that say risk, it gets very confusing. They don't really know how you're defining risk. They don't want to ask the patients what their behaviors are to figure out if they're high risk. I think it behooves us to just say 6 months, 12 months, whatever we think the best data shows. So moving on to diagnostics. How many people here use the traditional algorithm for syphilis diagnosis in their clinic or their setting? And how many use the reverse algorithm? Nobody. Do you know what the reverse algorithm is? Okay, good. So that's what this slide is to show you. Basically, the traditional algorithm is the one that we think of. You screen with the RPR test, and if that RPR test is positive, you confirm with a treponemal test. That's a TPHA, TPPA, FTA, whatever you have in your lab. The reverse algorithm does it backwards, where you actually start with a treponemal test, and if that's positive, then you go on to the RPR. It's backwards because who is a positive treponemal test going to pick up? Speak up, don't be afraid.
I heard somebody say history.
History. So a treponemal test often stays positive for life. So you're now screening with a test that may tell you the woman had syphilis infection 20 years ago, but she's pregnant today, and you want to know if she has active syphilis today. So many labs have moved to the reverse algorithm basically because they can do it in an automated fashion. It's easier for them. But there's questions about if this makes sense in pregnant women, which can cause a lot of stress if they have a positive test which has been treated before, and in men with HIV. Why would the reverse algorithm be a problem for men with HIV or high-risk men? What would you expect to see? In pregnant women, you expect low rates, usually about 0.5% will have syphilis positive rates. What would you expect in an HIV clinic with MSM? High rates. So do you want to use a treponemal screening test if you have a high-risk, high-rate population? It doesn't make sense. So let me show you the data that we saw. So this is from our pregnant women. We looked at all the women at UAB who delivered between 2012 and 2017. Under the traditional algorithm, that was 2012 to 2014. We had 9,000 women who had syphilis RPR. 0.5% were positive, so a very small number. Of those, only 24 had a TPPA performed, and of those, 30% of them confirmed being truly positive. This is many women who may have had a false positive test because the TPPA was negative and the RPR was positive. But in the setting of pregnancy, you're always going to err on the side of assuming the tests are real and offering treatment. When we went to reverse testing, starting with the EIA, we had 11,000 women tested. 0.7% were positive, of whom only 25% had a positive RPR. So many of these women probably had older infection. And when TPPA was performed on the ones with negative RPR, only 16 or 67% had positive TPPA. So there's a lot to unpack here. There's a lot of information about how we need to use this, but most OB providers I'm talking to do not even know which test they're using when they click the box. So they don't understand, they don't know the intricacies of explaining to the woman in front of them that a positive EIA may not mean that she has syphilis today. It may mean that her baby is at zero risk if she had syphilis 6 years ago that was completely and effectively treated. Does that make sense? So what we see, this is what I was mentioning to you in our HIV clinic with our MSM, is the opposite. So between 2015 and 17, of almost 1,700 men that we screened for syphilis, 800 of them were positive. Almost 50% of the men in our clinic had had syphilis in the past. So does it make sense in this population, do you think, to screen with this test, which is picking up all this old disease? Usually with screening tests, we want to start with a sensitive test and follow up with a confirmatory test that confirms, but not with a test that picks up just old disease. So I think we have some improvements to make in our diagnostics. And unfortunately, unlike all the great things we can do with gonorrhea and chlamydia and NAT testing now, this is not a PCR test. With syphilis, we're stuck on testing for antibodies that are present with disease that you've had in the past. Maybe in the future, we'll have better syphilis tests that actually pick up active replicating organism, which could be more meaningful. So you already saw some really beautiful pictures. I don't need to show you too many more, but just to remind you, I thought that was a great discussion of what a chancre should look like. You can get a sense of these heaped up edges where with your glove finger, you're going to feel that heaped up edge. Again, because this is painless, unless she comes into you with pain as the urine hits her vulva, She's not going to know that it's there, so do a careful exam. And all this discussion that we have in the public about presenting with STI symptoms is important, but what's been lost when I talk to the public is they think STIs always present with symptoms. We need to tell all of them, men and women, that 80% of the time it's going to be asymptomatic. If you have a male patient with this in his rectum, there is zero chance he knows it's there. Zero. Secondary syphilis, as you know, is when the spirochete replicates throughout your body and gets into your CNS and into your ocular fluid and into your lymph nodes. Usually presents with a rash, which can be any type of appearance, but classically maculopapular, involving the hands and the feet, palms and the soles. Alopecia is one of the clinical pearls. If you see someone with alopecia, secondary syphilis should always cross your mind. About 15% of the time you can have overlapping primary and secondary disease, and usually with secondary disease you expect a high titer RPR. So if I see someone with a 1 to 128, even if they have no symptoms, I look to see what their trend has been for their RPRs, but I'm telling them they most likely have secondary syphilis. Questions before we do a case?
What would you do if you had that patient with that rash and their RPR was not active? What would you recommend?
So there is about a 1 to 2 week delay between the treponemal test and the non-treponemal test. So it's possible the RPR is just not yet positive, so I would run a treponemal test to see if it was there. If it was negative and time passed, I honestly probably would still treat anyway in my clinic because my pretest probability is so incredibly high. But the testing is really good, so I would expect it to be positive RPR and TPHA after a couple of weeks. Prozone, so prozone phenomenon is when you have such high levels of treponemal pallidum in the blood that your test is overwhelmed and you have a false negative RPR. What the lab technicians tell me is with the current testing that they use, prozone is unheard of. So they say it's in the textbooks, everyone memorizes it for medical school, but as far as actually impacting our test results, I think it's pretty infrequent. Good question, though. Any other questions? Okay, so this is a 34-year-old with well-controlled HIV, 37 weeks pregnant. She's coming in for a routine visit with no complaints. She's tolerating her regimen. The standard regimen I use in pregnancy is boosted atazanavir and Truvada. She has not missed any doses. Her husband has HIV. He's on ART. Her labs are normal. She has an indirect bilirubinemia from her atazanavir, and her CD4 and viral load are good. The next day, because she does not have a point-of-care RPR test, you do not have a point-of-care RPR test, her RPR comes back at 1 to 64. What do you do next? If you're in my clinic, you're hoping her phone works. What do you tell her when you reach her on the phone? Any DIS officers? Where's our DIS officers? How would you manage this? What would you tell her?
Her that, her initial test was positive for syphilis, but my question would be, I don't know if the doctor, is doing a laboratory test. I'll try to get her back in to do a laboratory test to test her again and also ask her about symptoms.
So syphilis in pregnancy is a little bit different than what we do for a new HIV diagnosis. We're always cautious for an HIV diagnosis to tell someone we want to have a confirmatory test to be sure what we're dealing with. For syphilis, for an RPR 1 to 64, there isn't anything else that's causing this. There can be false positive RPRs of 1 to 1, 1 to 2, 1 to 4 just because of pregnancy. But this titer, in this scenario, I'm calling her and saying, it appears that you have syphilis. I want you to come in today to be treated. I would do extra tests when she comes, and we'll talk about that, but I wouldn't tell her that I need to do extra testing before I would treat. This warrants treatment right away. What's the other thing you want to tell her, obviously? Who else needs to be treated? Right, her partner, which she may not want to tell him that she has an RPR is positive. You all know that world well. So you treat her. You all know that the standard recommendation is benzathine penicillin, 2.4 million units once IM in clinic, 2 injections with 1.2 each. If she had latent disease, how would you treat her? Good. So we don't have to go over treatment. You all know that already. Her male partner is referred to the local STD clinic for treatment, but that's not the case. This is the case. She calls you the next day. She has fever to 38.4. She has malaise and body aches that started 4 hours after her benzathine penicillin. They've not yet subsided. She took Tylenol. Her fetal movement is present but decreased, and she's very anxious about what to do. Which of these options is preferred? I'm hearing some C's whispered. Anybody say anything else? Say again, speak up. It's a little hard. You could imagine different providers doing different things. The best thing, in my opinion, is to bring her back to clinic. I want to examine her. I want to make sure the fetal movement is there, the heart tones are there, and I want to evaluate her new fever. This is Jarisch-Herxheimer. This was first described by Jarisch in 1895, and then Herxheimer and Krauss in 1902. I grew up in Vermont, and we saw Lyme disease all the time. So at Dartmouth, we saw Jarisch-Herxheimer with Lyme disease. But it's also seen with tick-borne relapsing fever, lepto, and louse-borne relapsing fever, along with all those other diseases that can give you Jarisch-Herxheimer. It's not uncommon. 5 to 40% of people treated for infectious syphilis, and the first primary and secondary disease, can have Jarisch-Herxheimer. It's defined as an abrupt onset of fever, chills, myalgias, flu-like symptoms, tachycardia, vasodilatation with flushing, exacerbated skin rash, if they have a skin rash to start with, and mild hypotension. There are case reports of more severe disease that are described here, but really just case reports most of the time. It's benign and self-limited. This is important to recognize because you want to warn the patient this may happen to them. If you're treating them for the 1 to 128, if you're treating for a 1 to 256, those are the people this is most likely to happen in. And as you know, a tincture of time, if you tell patients what to expect, they always do better than if they are very worried, not sleeping that whole night because they think something horrible is happening to the pregnancy or to their health because they feel so sick. This is a nice analysis that was done in 2010 in CID, looking at some of the factors associated with Herxheimer reaction after penicillin treatment. And what you can see here is that it was more common in younger patients, more common in early syphilis compared to late syphilis, more common with high titer disease, at least 1 to 32 or greater, and less common in people who had syphilis treatment in the past. So if you know this is a true incident syphilis infection, the Herxheimer is more likely to happen. What is it? What I tell the patient is that penicillin is killing all those organisms. Those organisms are breaking up in your body and causing this big inflammatory response. The good thing about Herxheimer is it predicts treatment response. People who are having a Herxheimer are killing this organism, and they often have a very rapid fall in their RPR. It's thought to be a cytokine storm, and there's activation of complement and TLR pathways, but a lot of research still trying to understand exactly what's happening. In pregnancy, you can't have fetal distress. You can't have preterm delivery, so she's right to be worried about the baby. And in one small study, this was from 1990, they took 33 women with early syphilis, treated them, and admitted them to the hospital to watch them every hour to see what happened. When they watched them every hour, 73% had fever, 67% had contractions, and 67% had decreased fetal movement. The onset of the symptoms was 2 to 8 hours after treatment, so right when they, midnight after you've seen them in clinic, with peak at 6 to 12 hours and resolution by 16 to 24 hours. So when you warn the woman or you warn the non-pregnant person about this, you tell them you may feel bad for about a day. After that day, you're going to feel okay, but call me if it happens so you can discuss it with them. Because the other thing that they're going to be worried about and providers are going to be worried about is penicillin reaction, right? They're going to say, is this a drug reaction? So you want to have that in your differential as you're talking with them. So what I do is warn her or warn them about the possibility of JHR, have her monitor for fetal movement and early labor, and ACOG recommends even consideration of hospitalization. So some OBs do this, some do not. They give the first dose in-house, monitor for 24 hours, and then let the woman go so she can be monitored in that setting. The vast majority of women have self-limited symptoms that resolve by 24 hours. Candice and I were doing a project together a couple of years ago now. We were calling providers and calling states, actually, to find out what some barriers were to preventing syphilis in pregnancy. And we heard from some OBs who said they didn't even want to look for syphilis because they're so worried about Jarisch-Herxheimer. That doesn't make any sense. This is a reaction that's self-limited that if you warn patients, you can manage. This is not a reason to not look or screen or treat for syphilis in pregnancy. And as you know, benzathine is a standard therapy, and if a woman is truly allergic to penicillin, she gets admitted to the hospital for desensitization. This is a very nice letter that came out as a public health advisory to all the medical providers. You all have probably read this, November 9th. focusing on the increase in congenital syphilis in North Carolina and giving some really nice bullet points, telling providers to make sure that they perform a thorough sexual health and risk assessment at every prenatal visit, and also telling providers that just doing the initial screening is not enough, because 2/3 of the cases with congenital syphilis in 2017 had a negative initial test, meaning if you don't do follow-up screening in pregnancy, you will miss these cases. The North Carolina public health law is to screen at the first visit, to screen at 28 to 30 weeks, and to screen at delivery, so 3 screenings. About 17 states now have mandated third trimester screening, but North Carolina is they're very clear that women should be screened 3 times. Questions about Jarisch-Herxheimer? Hopefully I'll leave some time for questions at the end. So this is moving into, this is a presentation that I gave a couple weeks ago. This is a study where we wanted to look at the women. What I was noticing is that in many reports of syphilis in the US, all the discussion was in MSM, because most of the cases are in MSM, and no one was saying anything about women. And there were questions about, are the women getting the syphilis from men who have sex with men and women? Or the women getting syphilis somewhere else? Is there a heterosexual syphilis epidemic and an MSM syphilis epidemic? These were the questions. And about a month ago, Sarah Kidd with the Division of STD Prevention in CDC presented this data looking at the patterns of drug use in women and men with syphilis in the US. And what she saw is when you do this nice gender stratified analysis, there is an association between drug use among women between 2013 and 17, tracking with the increase, but not among MSM. So just a hint that maybe what's happening is different. In women, this is related to the opioid epidemic, and in men, it's MSM is the risk factor and not drug use. We thought we'd look in people with HIV to see if that was the case. So our hypothesis was that predictors of incident syphilis in women with HIV are different from men. We're not all the same, you know. This is the data that we use for this analysis is from the CFAR-CNIX network. So there's 8 hospitals across the country that have followed adults with HIV with their medical charts since 1995. And one really beautiful thing about this data set is we have patient-reported outcomes. So our patients who are part of this study, before I see them in clinic, this is our social worker showing you how it works. They fill out questions on a touchscreen computer. How many partners have they had sex with? Men, women, or both? Did they use condoms for vaginal and anal sex? Do they use methamphetamine or cocaine? How much alcohol did they drink? All these questions that providers don't always ask, that patients aren't always comfortable answering, are at least asked in a way that's private, where they can put information and we can track it over time. So with this data set, we had about 4,800 women in HIV care at these 8 sites. Almost all of them were tested for syphilis at least once between 2005 and 2016. 417 women had positive syphilis testing. And we had 119 women who had 125 positive cases of incident syphilis during follow-up care. Most people in HIV care, as you know, are seen every 3 to 6 months, so we had a lot of visits over time for women. What we saw when we made our prediction models is that, like we hypothesized, of the women who admitted to active drug use, this is cocaine, opioid, and methamphetamine use within the past 3 months, they had a higher odds ratio of 3.3 for incident syphilis compared to women who did not use drugs. Number of sex partners you see approach statistical significance, so I think that's still related. And we didn't have a specific question about transactional sex. We were very curious, are you having high-risk sex to support your drug habit? It wasn't asked in CNIX at that time. We made this measure of greater than 6 sex partners, but we're going to ask the question going forward. This is the larger model where we looked at all the other factors that we had in our data set. And what we found, number 1, is that age was not predictive. Gonorrhea and chlamydia, again, 18 to 24, always highest risk. So we need to be screening 40 and 50-year-old women for syphilis when they're in HIV clinic, even if they're not 20 years old. Black women had a 2-fold higher odds of incident syphilis. And surprising to us, women with an IV drug use HIV acquisition risk factor had 2-fold higher risk, higher odds, and women with hepatitis C co-infection about 2-fold higher odds. So we think these 2 things go together. We think that the IV drug use and the hepatitis C are measures either of active drug use or prior drug use. And this supports that national data that maybe what's happening in women is this intersection between opioid abuse, drug use, and syphilis. So in conclusion, rates of primary and secondary syphilis in adults are rising. This is leading to more congenital syphilis, which we would like to stamp out. HIV, syphilis often go together, so you have to think about them and co-infection in every scenario. A new syphilis infection in someone with HIV should prompt a discussion of or referral for HIV pre-exposure prophylaxis. Adults with HIV should be screened at least annually. I would argue more often than that, but until I have the data for you, I won't tell you exactly how often. I don't know yet. Women with HIV and IV drug use or hepatitis C infection are at risk of syphilis and probably warrant more frequent screening. And syphilis screening is really the key to our public health response. The only way we can pick up this asymptomatic disease, which is easily cured, is by looking for it. So we have to look for it frequently, especially in our high-risk patients and clients. Infection is asymptomatic. We talked about that already. And then the reminder of the North Carolina laws. Penicillin G is a drug of choice, desensitization we mentioned, with no evidence of resistance in T. pallidum. The press still gets confused. I think we talk a lot about gonorrhea resistance, and they assume that means every STI is highly resistant. So remind your patients when you talk to them, this is not a case where antimicrobial resistance is important, not yet. And the strong partnership between clinical providers and public health professionals is the key to coordinating this response to rising rates in the U.S. We only can do it together. This is not my slide. I had a picture, a nice picture of the Appalachian Trail in North Carolina, but it's not here now. So I would love to hear any questions or comments that you have. Is that supposed to be a question they have to answer, or?
Yeah, I'm going to get the Betsy slide here.
Questions? Yes.
So going back to that slide about how a lot of syphilis cases are like it's not being in STD clinics. We have had that where people are improperly managed outside. And so do you have any suggestions on how we can do better or build up better relationships or get better training for that sector?
I mean, I can tell you this is something that, I'm going to let Candace answer this in a minute, that CDC thinks about all the time and state health departments think about. Oh, sure. So the question was, there are cases that are being seen in the community where syphilis is either mismanaged or misdiagnosed by providers who are not familiar with STI management and care. And the question is, how can we partner better to improve the knowledge base? I think that there is a lot of interest and effort put into trainings like this, put into online trainings, to try to get all providers at every level seeing these patients comfortable. I think that bringing them up to the level of an STI provider is going to be very challenging. These are providers who have a lot on their plate, and they see their role as different than the STI HIV provider does. So I think that your question of partnership is a really good one. The more we can do to have simple guidelines, posters, reminders on the computer that say screen this person because they meet age and cutoffs and behavioral cutoffs, to bypass a provider needing to memorize or remember what to do, I think is going to help. But I think your point's very well taken. I think the perception is still from many people that this is managed in STI clinics, and that's why that slide is helpful. It's not the case. It's the family doctors sometimes, like who I said, are calling me and not sure what to do. So they admit that they are in need of some more information. But let me let Candace add to that.
I will agree with you. I think education is the key here, and we do, in partnering with the state, have several of these opportunities where we'll be educating the community about this. The other thing is to consider routinizing screening in that, people who are into technology, finding a way for EMR prompts and things like that so that people know which groups need to be screened more routinely. Also getting out there in terms of education with people so that they know, because of my risk, I should be coming in for screening at this type of frequency. So having that shared relationship where they know their risk and you're going to be there to help them out in getting their appropriate screening done.
Good question. Other questions?
You just pick one.
Oh, I see. Any treatment-resistant cases? No. I can tell you that people are looking and there's some discussion, 0, 0, 0. Every single case of T. pallidum that we are seeing across the globe is exquisitely sensitive to penicillin. And in infectious disease, I treat a list of infections like this long. The proportion that is sensitive to penicillin is this big. So I'm very happy that T. pallidum is on that list. It doesn't It doesn't get those resistance mechanisms the way something like a gonorrhea does, Neisseria does. Secondary syphilis is when bacteria enters the CSF. Secondary syphilis is the dissemination of the spirochete throughout the body. So primary disease is a chancre at the site of inoculation. You can tell where that chancre is, where the person got exposed. Secondary is when it spreads. So if you're pregnant, that's when it crosses the placenta. If you're not pregnant, lymph nodes, CNS tissue, ocular tissue, this is where it can get into your aorta. This is a very smart pathogen that knows how to cross our barriers very well inside our body, so it goes almost everywhere. And that's what leads to tertiary disease. Some of the dreaded long-term complications of syphilis is untreated primary and secondary disease. Will Ryan White pay for syphilis testing every 3 months? Good question. So I think that the question about how often people are going to be, what the reimbursement is going to be always drives screening questions. In general, whether it's ACIP or Ryan White or CDC, the recommendations have to follow good data. So that's why I was saying we need to pool our data. We need to do modeling with biostatisticians I'm working on now to say, if we screen every 3 months, we're going to pick up this amount of disease given the population prevalence. We're going to miss this many cases, and this is what it's going to cost. If we screen every 6 months, this is what we're going to pick up, this is what we're going to miss, this is what it's going to cost. You can do all those breakdowns with different cut points, and then let the policymakers and the people decide what is appropriate. But I would argue, as we're in record high rates of STI in the US, we need to move into more screening and not less.
Time for a few more.
See, this is fun. It's like pick the one I feel like answering.
This one?
Yes. So I think that penicillin is the drug of choice, and you want to use it every time that you possibly can. About 1 in 4 people in the country think that they have a penicillin allergy, and we spend a lot of time in infectious disease talking with them and clarifying that even though they had a rash when they were 2, they've had 10 different penicillin antibiotics since then and have done fine, so they can get benzathine penicillin without a problem. There are ongoing studies documenting this even further, where the real true penicillin reaction rate may be way less than 1%. So you don't want to give a secondary drug when you can give the primary drug most of the time. So in infectious disease, we are often more comfortable managing allergies than some people are in the community. So we will take those risks. I'm always crossing off these allergies on their chart because I say they are not allergic to vancomycin. They got it 3 weeks ago. They're on it today. Why is it on their allergy list? That's one of our, you got me up on my soapbox. If it is a true pen allergy, if the patient says, I developed welts and hives and my throat swelled up and I was in the ICU on a breathing tube, this is a very small number of patients that will say this, then I will say, okay, we will not give you penicillin unless you're pregnant. You're pregnant, I admit them to the hospital and they get penicillin. Then you can look at other options. Doxycycline is something that you can consider using. It's not as effective. You consider it inferior. I do everything I can to try to give penicillin or ceftriaxone. Any other questions in the room before I give all my attention to the questions on the... Is TPPA more sensitive and specific than EIA? Yes. Can I go back?
To your side?
Yeah.
Yeah.
Is it possible?
Yeah. Which one? Here.
The one that is TPPA, TPHA. Here. Yeah.
Okay.
So the question is EIA less sensitive than TPPA? And the answer is yes. The EIA is the test that's being chosen because the lab can put this on the automated machine. It's the one that's available. In pregnancy and in other populations, if you follow here with me, so of all these EIAs performed, there were 83 that were positive. Of those, 25 had a positive RPR. This is evidence of true active syphilis. The woman gets treated. Of the women who were discordant, EIA positive, RPR negative, there's a few different possibilities. This may be someone who had syphilis a long time ago that was successfully treated and she's not infected now. Or it may be someone who has a false positive EIA who doesn't have anything at all. what you would do when you're in this box is say, I need more information. I need another treponemal test to figure out if this EIA is true positive or false positive. And then we go to the test that we trust that we have the most data on. TPPA is probably the best treponemal test that we have. In this setting, you would do a TPPA on 24 of these women, and only 16 or 2/3 of them are positive. In some studies in pregnant women, only 50% of the EIAs confirm positive with a TPPA. What's the interpretation of that? What's happening? We're having these false positive EIAs, or these EIAs that don't confirm with a TPPA or TPHA. So maybe we're telling a lot of women that they have syphilis when they have nothing at all because their TPPA is negative. Not all, but some. So yes, I think part of the answer is that this EIA is not as good or not as sensitive as the TPPA and TPHA are. The TPPA, at least for now, is not automated, so you can't start with the TPPA in most labs. That would be one solution. The other solution that we're looking at now is to look at the titer of the EIA. This is one of those tests that's in the background in the lab. They won't give it to you, but if you call and beg, sometimes they'll tell you what the number is. And a very high titer EIA, over 8 for some of the tests, is almost always confirmed by a TPPA. If you have an EIA that is borderline positive or low positive, it's a 3 or a 4, those are often in this box where they don't confirm with a TPPA. So although the lab can't give you that information, it's not approved to be used in that way as a quantitative test, that's the direction that we're headed. And I think as we work to make our syphilis diagnostic algorithm better, we need to improve this EIA. We can't have the performance of this test where in men with HIV, it's picking up something which is disease from 30 years ago, and in women who are pregnant and very anxious today, it's picking up a lot of women as positive who have nothing. So this is an area where we need to do more research. I think I'm at time. Go ahead.
So if you do antibody test twice, the titer comes back negative twice, the patient doesn't know if he or she ever had symptoms before the might come back positive.
Let me understand. So you're saying that the RPR is positive.
And the titer is negative.
The RPR is positive, but the titer you're seeing is undiluted or is 1-to-1 reactive?
Or it says doesn't have any titer whatsoever, but the antibody is positive. She doesn't know, or he doesn't know if nobody's ever told him that they had syphilis, or so would you treat them?
So it's very common for people to come in and have a positive low titer RPR with a positive confirmatory test, TPHA, TPPA, which is evidence of true syphilis either now or in the past, and then to say, no one has ever told me anything about this. It's the same when you screen them for hepatitis B or C or even HIV. These diseases are often asymptomatic, and we're not looking hard enough, so it's often missed. If that person says to me, no one's ever told me about this, in my mind I say that means there was syphilis either today or in the past that has not yet been treated, I'm treating them. If they are EIA positive, RPR negative, it's a little more difficult because that's a setting where it really does look like it's cleared. And over time, with and without treatment, your body will clear the infection. If it's isolated EIA positive alone, I would still treat them if there was no evidence of treatment in the past. But that phone call to the health department to say, do you have this person in your records where they treated 10 years ago, saves you a lot of time and energy. He'll say, oh, I was treated, in 2007. I just forgot. Okay, thanks, everybody.